Okay, good morning everyone. So today we will take a few questions from medicine. Now starting with the very first question, and here elderly male presented with the diffuse weakness, tingling of his arms and legs. Good morning Joycey, good morning. And when the neurological examination was done, it was revealed that there is weakness of the extensor and flexor muscles of the lower extremities. And most importantly, the sensations of vibration and position is decreased in all the extremities. So if we look clearly to the question, there is one very important clue which is given here. Vibration sense, position sense is decreased in all extremities. So in upper limb as well as lower limb, there is decrease in the sensory modalities like the vibration and position sense. Now if we know a little bit about the neurology, like which fibers or which tract conduct these impulses, the vibration sense and the position sense is carried by the dorsal column medial lemniscal system, right? So this is dorsal column medial lemniscal system, fine. So it means there is some affection of the dorsal column, right? And that is evident by reduction in vibration sense, reduction in position sense. Now the important thing is that involvement of upper limb and lower limb both are there. So it means there is some condition which is affecting the dorsal column and all the four limbs. Now this condition is related to some vitamin deficiency, and there is only one vitamin deficiency. This can give you this kind of neurological picture where there is affection of the dorsal column, and that is vitamin B12. Clear? And the clinical condition, whatever is discussed here, this is the subacute combined degeneration. Right? So the clinical condition which is discussed in the question is SACD. So subacute combined degeneration, and this is associated with vitamin B12 deficiency. And if we go little bit in the anatomy of the dorsal column, now dorsal means posterior, right? So this is posterior. So if you look in the spinal cord, this is the anterior portion or the anterior side, and this is the posterior aspect of spinal cord. Clear? And this all area is the dorsal column. So this is of one side, and this is the dorsal column of other side. Right? This is the midline. Okay. Now if you see in the dorsal column, you can see one more partition. So you can see one partition here, one partition here. Now what is this partition meant for? This actually reflects that this area is different and this area is different. Clear? Although both are included in dorsal column. So this one is related to the lower limb, and this is known as the fasciculus gracialis. Clear? So fasciculus gracialis for lower limb, and this is the fasciculus cuneatus for upper limb. Right? So this is in short about the anatomy of the dorsal column. The medial portion is related to lower limbs. Clear? So this is all for lower limb, and the lateral part of the dorsal column, this is for upper limb. So upper limb fasciculus cuneatus and lower limb fasciculus gracialis, and the sensory modalities which are carried away by dorsal column are vibration sense, position sense, stereognosis, clear? Or you can also say proprioception. So if in a question, if you see any mention of the affection of dorsal column modalities in relation to vitamin deficiency, always and always your answer has to be vitamin B12, right? So this is how you have to reach up to your answer. Then moving forward, there is a 12 years old girl from Nigeria, and then she is having night sweats, fever, loss of weight since few months, and she was having an intra-abdominal mass and enlargement of the peripheral lymph nodes. When a biopsy was done, a biopsy of the lymph node was done, there was sheets of lymphocytes and there were interspersed macrophages. Now here are certain very important clues, like the age is 12 years, then female, from African country, Nigeria, clear? Then this is one group of information. Then another on histopathology, what we can see. What we are seeing is histopathology. One is plenty of lymphocytes, clear? So plenty of lymphocytes, and in between those lymphocytes there are few macrophages. So actually what happens, these lymphocytes, they are like plenty in number, and this will give a blue appearance. And these macrophages are few and they have, clear cytoplasm, and therefore they look like you can say stars. And the blue appearance of lymphocytes is sky. So the word which I am going to derive here is the starry sky appearance. So this is actually the word which I want to say is starry sky appearance. So the moment you have this kind of presentation, I think most of you can just move on to the diagnosis, and this is nothing except Burkitt's lymphoma. Clear? So this is Burkitt's lymphoma. Very easy. Right? The moment you see any case history starting with African, especially related to hematology, always think of Burkitt's lymphoma. So here you can see the patient having enlarged lymph nodes, African in origin, and this is how the starry sky appearance looks like. So this is the starry sky appearance. You can see plenty of blue dots here. These are all lymphocytes, okay? So these blue dots are all lymphocytes. Fine? So these are all lymphocytes. And in those blue dots, you can see few white areas. And these white areas are actually macrophages with clear cytoplasm, right? So these are macrophages. And these looks like stars, and the lymphocytes, it gives an appearance of blue sky. So this is known as starry sky appearance, right? So this is Burkitt's lymphoma, and the translocation is T8 to 14. So just remember this much. Fine. Then moving forward, another question. A 10 years boy complains of lethargy, and then his mother told that he was initially good in studies, but now he is not studying well, and there is history of repeated blood transfusions. And when a peripheral blood, Avinash, good morning, and when a peripheral smear was made, we can see crescent shape RBCs. Now this word is very classical. Crescent. Now how the word crescent is something like this. So this is what is crescent. So when you see RBCs which are crescent shaped, I think there should be no doubt in your mind that probably this is a case of sickle cell anemia. Right? So sickle shaped RBCs or crescent shaped RBCs. And this is a classical peripheral smear where you can see a sickle shaped RBC. Right? So this is how the peripheral smear will look like, and the clinical presentation is something like this. Clear? So it's not like the condition is not, the sickling is not present all the time. It's especially in some conditions, like if there is a infection or if there is dehydration or deoxygenation. So all this will promote sickling, and when there is sickling, obviously these cells will break down, leading to hemolysis, or there can be vaso-occlusive crisis. Clear? So there can be vaso-occlusive crisis as well, because they can go and they can occlude the vessels. And characteristically, if you have noticed few features like bone pain, or there is priapism, there can be avian femoral head, and in cases of spleen there might be autosplenectomy. Right? So this is typical of sickle cell anemia. Then moving forward, a young lady presents with hematuria, that is blood in urine. Okay, so hematuria. So hemat means blood, urea is in urine. So there is blood in urine. There are ecchymosis, means subcutaneous bleeding spots, and there is menorrhagia, means excessive menstrual blood flow, and this is present 6 months. Now what is the diagnosis here? Now if you see, the lady is having bleeding tendencies. Clear? So the lady is having bleeding tendencies, and this suggests that there is decrease in platelet count, and that is known as thrombocytopenia. Clear? So this is thrombocytopenia. Fine? So cytopenia is less cell count. Now this condition, which is especially seen in young females, this is ITP. Clear? So this is idiopathic or autoimmune thrombocytopenic purpura. Clear? So ITP. And this is how the purpura or the ecchymosis looks clinically. You can see so many bleeding spots under the skin. Clear? So this is, you can say, purpura or ecchymosis. So this is classical presentation of ITP. This is idiopathic, or you can also say immune, because there is a immune mechanism, there is autoimmunity, there are antibodies which are directed against the platelets and they destroy the platelets. So this is ITP, and here there is autoantibodies which are actually affecting the platelets or destroying the platelets. Now this condition is bimodal. It means it can be seen in childhood, it can be seen in adults, especially it will be seen in females less than 40 years. Clear? So that is a classical presentation. Although children can also be affected. So this is ITP, that is immune or idiopathic thrombocytopenic purpura with bleeding tendencies. Then moving forward, a case of hypertension has palpitations, dyspnea, shortness of breath, and there is development of encephalopathy, brain dysfunction. And when you check the blood pressure, it was 220/140 millimeter of mercury. Now, what treatment should not be used? Now, if you look here, the BP is so high. So, blood pressure 220/140 millimeter of mercury, number one. And number two, what you noticed, there is encephalopathy. It means there is involvement of brain as well. So, this is actually known as end organ damage. Right? There is one more point related to end organ damage, and that is shortness of breath or dyspnea. Clear? So this is also end organ damage. So it means BP is extremely high, there is end organ damage. So this is hypertensive emergency. Clear? So this is hypertensive emergency, fine, because there is raised blood pressure plus end organ damage. And for hypertensive emergency, you have to give intravenous antihypertensives under ICU setup. So this is the line of management. Now if we look at the options, nicaridipine is antihypertensive, sodium nitroprusside is antihypertensive, esmolol is antihypertensive. Now this mannitol is not an antihypertensive, this is actually osmotic diuretic agent, and this is specially used to reduce intracranial tension, right? So it has nothing to do with reduction of blood pressure, right? So here the answer will be intravenous mannitol, and this is a classical case of hypertensive emergency. So hypertensive emergency, the blood pressure is extremely high, and this is associated with end organ damage. It can be in the form of CNS, respiratory system, cardiac involvement like acute coronary syndrome and all, right? So this is hypertensive emergency, and in hypertensive emergency, the patient has to be in ICU, intravenous antihypertensive agents have to be started, and the principle is like in initial first hour, we have to reduce the blood pressure by around 25%. Then in the next 4 to 6 hours, we will reduce the blood pressure below to 160/100, and within the next 2 day, we will take the blood pressure down below to 140/90 diastolic blood pressure. So that is the usual pattern of management of hypertensive emergencies, right? If there are no end organ, if these are absent, then it will go in hypertensive urgency. Clear? So this is hypertensive urgency, and then urgency can be managed by oral antihypertensives. Fine? So this is the basic difference between the two conditions, hypertensive emergency and hypertensive urgency, and the management also differs, right? So the moment you see any end organ damage, it can be in the form of CVS. We can write palpitations here, right? So it can be in the form of CVS, respiratory system, or CNS. This is end organ damage. So high blood pressure, yes, Mihir Pant, absolutely, is indicated in cerebral edema. That what leads to raised intracranial tension. Yes, it's indicated. So this is classical for hypertensive emergency, and here the blood pressure has to be reduced under ICU setup, giving intravenous antihypertensive agents. Clear? So this is a basic plan for hypertensive emergency and how it differs from hypertensive urgency. Clear? So urgency and emergency. Then moving forward, now this is one of the question which has been repeated many times over the years, right? So it has been repeated many times, and here a patient has raised jugular venous pulse with a steep Y descent. The moment you have this word, steep Y descent, I think there should be no confusion whatsoever, and the answer has to be straightforward, constrictive pericarditis. Clear? So the moment you find this word, steep Y descent, don't look at any other thing in the MCQ statement. Straight away, search for constrictive pericarditis, mark it and go ahead, right? Mihir Pant, we will come back, we'll come to that question also, don't worry. So for the time being, this is constrictive pericarditis, and here you can see what is a steep Y descent. This is how the steep Y descent looks in a case of constrictive pericarditis, right? So rapid steep Y descent in constrictive pericarditis. Mihir, you can just keep your message on, because I have kept that question also. So here the blood, now moving forward to next question, there is blood pressure of 80/40. Now I think most of you must agree that this is hypotension, right? So this is low blood pressure, hypotension. Then there are soft heart sounds. It means there is some collection around heart, and we know that the collection is, it can be blood or it can be fluid. It's a bad conductor of sound, and therefore the heart sounds are not heard clearly, right? And third, absent Y descent on jugular venous pulse. So the moment you have these three classical features, I think Mir Bhai has already gave us the answer. This is nothing except cardiac tamponade. Clear? So this is cardiac tamponade, and yes, we can take the backstride here. It's very important. So in backstride, one of the component is hypotension, second is muffled heart sounds, and third is raised JVP. Clear? So this is the backstride of cardiac tamponade. Now cardiac tamponade is rapidly developing pericardial effusion, right? So maybe there may be possibility that at times, just to confuse you, they won't give you cardiac tamponade in options. So in that case, you need to search out for pericardial effusion, right? So cardiac tamponade or pericardial effusion, and tamponade is actually a pressure effect. Whatever the amount of collection is there in the pericardial cavity, it will press upon the heart, right? So this is the moment you find this word, absent Y descent, please remember cardiac tamponade, and steep and rapid Y descent, please remember constrictive pericarditis. Now it's all up to you how you can make your mnemonic, but just make sure that you don't mix up between the two conditions, and it's a very important segment from exam point of view. Okay, then moving forward, a case of Marfan syndrome. He comes to the department with severe tearing pain, which is in the chest anteriorly, and then radiating backward to the interscapular area with sweating and weakness. On examination, the blood pressure was 200/140 millimeter of mercury, and X-ray chest shows widening of superior mediastinum. There is sinus tachycardia on ECG. Now here, one important condition is Marfan's syndrome. Clear? Then the clinical presentation is very specific for the answer here, whatever the answer we'll take later. So the pain will start in the chest anteriorly, and the patient will say that it is piercing my chest and radiating to the back between the two scapula. So the moment you have this kind of presentation, the answer is nothing except aortic dissection. Clear? So the moment you have this kind of presentation, you need not look at any other thing. Straight away jump to the answer as aortic dissection, right? But here, just for the sake of MCQ, we can take few more terms like BP is extremely high, and this is the reason why the blood flow is tearing through the walls of the aorta and entering through the tunica intima. Now there is widening of superior mediastinum, and this is because there is widening of the arch of aorta, because the blood, rather than flowing into the lumen, is going through the walls of the aorta, right? So this is very specific case of aortic dissection. And suppose if this is tunica intima, this is tunica media, and finally there is tunica adventitia. So what happens? The blood is normally supposed to flow like this, but what is happening? The blood enters into the walls of the aorta. So this is known as aortic dissection, and the flow of the blood is so fast and so, with velocity, it will separate out the layers. So the layers will become something like this. So like this, right? And the blood is all flowing within these two layers, right? So this is how we define the aortic dissection. Very good, Mihir, very good. Okay, so this is aortic dissection. The blood tears the intimal layer, the outer layer, and then there is blood within the muscular layer, right? So again, long standing untreated high blood pressure. This is one predisposing condition, and especially in cases of Marfan syndrome, we can see this aortic dissection. Clear? And this clinical presentation is obvious. The moment you have this word, straight away aortic dissection. Then moving forward, a patient, 20 years old lady, presented with joint pains. Okay, so it's a young lady with joint pains and a rash over face. There is no fever as such, and on blood examination we can see raised ESR. Now what is more important here, that she had small warty vegetations which are present on both the sides of the heart valve. So suppose if this is the heart valve, the vegetations are present here and the vegetations are present here. So on the both sides. Now what is this condition? Young lady, joint involvement, rash over face with vegetations on either side of the heart valve. Now this is a classical case of Liebman-Sack endocarditis. And I think most of you must be knowing that it is present in SLE, right? So this joint pain is actually non-erosive arthritis. Then this rash is actually malar rash, or what you call butterfly rash. Okay, so this is how you need to connect the words, and you can reach up to your answer as Liebman-Sachs endocarditis. Very good, Mihir. This is SLE, but Liebman-Sachs, right? So here you can take S here, then you can take L here and E here. So this is how you can just correlate, right? So this is Liebman-Sachs endocarditis for SLE. Fine. So here you can see the vegetations. Now moving forward to second heart sound, and here the question is about the pattern of second heart sound. It is fixed and it is widely split. Now to understand this question, or to answer this question, you need to understand the basic physiology. Like this is, now there are two components in second heart sound. One is the aortic component and second is the pulmonary component. So we write the word 2 because that is related to the second heart sound. A for aortic, P for pulmonary. And unlike the first heart sound, the two components doesn't coincide, right? So here there is a gap between the two components. Clear? There is a gap, and suppose this is in expression phase. Now this is, I am talking normally. Now suppose if this is an expression phase, what happens in inspiration? There will be more gap, right? So the gap will increase on inspiration. Now this is normal physiology. The gap between the aortic second heart sound, pulmonary second heart sound component increases during inspiration. Now when I say wide split, now wide split means the gap will increase more than what was present normally during both the phases. So like this and this. So you can see here the gap has increased what was there in the normal state in both the phases, right? So this is known as wide split. Clear? This is known as wide split, because the split has increased in both the phases of respiration. Now there will be one more condition where the gap between the two has increased in expiration, but the same gap, the same length of the gap will remain in inspiration as well. So if you see here, this is of course more than normal, but this is the same in inspiration as well if you compare it with the wide split. So this is known as fixed. Of course this is also wide split. So the moment I am using the word fixed, it means same in expiration and inspiration. Clear? So it is same in expiration and inspiration, but yes, more gap than normal. So you understood this word? If I am using the word wide fixed, it means the gap is more than normal, but it has nothing to do with the phases of respiration. It remains same in expiration or inspiration. Otherwise, if I am simply using the word wide split, it means the gap is increasing in expiration and it is increasing further in inspiration. Clear? So I think this much description will help you. Now when we are using the word wide and fixed, the answer has to be a fixed, and that is only one condition, ASD. Clear? Atrial septal defect. So there is only one condition which you need to remember for fixed wide splitting of second heart sound. So the moment you find the word fixed, the answer has to be fixed, ASD. Right, Avinash? No problem. We, as a human, we all can make errors, but I am very sure at least till exam you will remember this concept. Right? Now, this is in relation to this question. Just some more terms like for wide split. Now here we know that there are two components, aortic and pulmonary. Now the wide split can occur in two conditions. Either the A2 closes early, P2 remains at position, right? Or A2 remains at position and P2 delays lately. So P2 delay or A2 early. Clear? So this can lead to wide split. Either there is early closure of A2 or there is delayed closure of P2. Now P2 can be the P2 component, which is actually the pulmonary component, closure of pulmonary valve. It can be delayed if there is conduction which are reaching very late. So right bundle branch block or pulmonary stenosis. Clear? So this is like delayed closure of pulmonary valve as the conduction is reaching late up to the pulmonary valve, or there is stenosis of the pulmonary valve. Clear? So this is one cause of wide split of second heart sound. Now my question is like, if this is suppose A2 P2. If the impulses are delayed for aortic component, so what will happen? See, the pulmonary will be at the same spot, but A2 will be delayed and it will go beyond P2, right? P2. So this is when the impulses are reaching late for aortic valve, that is either by left bundle branch block or aortic stenosis. Now these are the same conditions which we have discussed for delayed closure of pulmonary valve or P2. So here what will happen? The P2 will close at its own time, but the A2 will close after P2. So A2 will come after P2, and therefore now what is happening? The normal is A2 P2. Okay, this is the normal sequence for second heart sound. But what is happening here? P2 A2. So this is reverse or paradoxical splitting. Fine? Because the normal teaching is that A2 followed by P2. But what is happening here? P2 followed by A2. So this is going against the normal teaching. So it is paradoxical or reverse splitting. And why there is delayed closure of A2? Because either the conductions are reaching late or there is stenosis of aortic valve. So this is a very beautiful concept. If you can understand it properly, I am very sure you will never mix up. Clear? Now moving forward to pulsus paradoxus. Now there are many conditions in which we can find pulsus paradoxus, where we can feel pulsus paradoxus. Now for that you need to again remember the basic concept. Now what happens if we take the blood pressure, the systolic blood pressure, say during expiration, say it is 120 millimeter of mercury. Now what happens during inspiration? There is a fall in systolic blood pressure, but it will never go below 110. So it may be between 110 to 120 somewhere. So it means there is a fall in systolic blood pressure on inspiration, and the magnitude is always less than 10 millimeter of mercury. Clear? This is normal. This is normal teaching. Now what happens in certain conditions, this fall is more than 10 millimeter of mercury. In systolic blood pressure, on inspiration, the fall is more than 10 millimeter of mercury, and this condition is known as pulsus paradoxus. So what we say, this is an exaggeration of the normal physiology. What the value which was supposed to be less than 10 has now moved beyond 10, right? So here you can say the systolic blood pressure might be 105, you can say something like that, right? So the reduction is around 15 millimeter of mercury. So this is pulsus paradoxus, and this is exaggeration or increase in the normal physiology, exaggeration of normal physiology. And here we have two set of conditions. It can be lung conditions like COPD, it can be heart conditions like constrictive pericarditis or cardiac tamponade. So just remember important ones: cardiac tamponade, constrictive pericarditis, and here it can be COPDs, severe bronchial asthma and all, right? So this is pulsus paradoxus. And here the paradox is that if you auscultate, you will hear the heart sounds, but if you palpate, you won't feel the pulse. So that is the paradox here. Then moving forward, a patient is having a pH of 7.28, bicarbonate of 23, and PCO2 of 80. Now pH, now just to solve these kind of ABG questions, you need to know the normal values. So pH is 7.35 to 7.45. For bicarbonate, this is 22 to 26, and for PaCO2, this is somewhere between 35 to 45. Clear? So obviously, if the pH is less than 7.35, this is acidosis, and if it is more than 7.45, this is alkalosis. So in our question, the pH is 7.28, so this is of course acidosis. Now acidosis can be because of two reasons. Very good, Avinash. It can be because of two reasons. Either there is increase in PaCO2 or there is decrease in bicarbonate. So there are two reasons only. If it is because of this, we will call it respiratory acidosis. And if it is because of this factor, we will call it metabolic acidosis. Clear? So looking at our question, the bicarbonate is normal, but the PaCO2 is high. So our answer will come out to be respiratory acidosis. Very good, Avinash, right? So this is the answer here. Then moving forward, a elderly male has imbalance while standing, right? And there was loss of proprioception and vibration sense. I think now most of you can straight away reach to the answer that this is the condition which we have already discussed. So this is subacute combined degeneration, and we discussed that it is because of deficiency of vitamin B12. So obviously we need to give vitamin B12 to this patient, right? So this is subacute combined degeneration as a CD, and there is affection of the dorsal column. Clear? So this is, I think most of you can answer it now. Now ECG of a patient is showing wide QRS complex and tall T waves. The moment you get this word, tall T waves or tenting of T waves, I think there has to be no confusion whatsoever to make your diagnosis of hyperkalemia. So excess of serum potassium, right? And in fact, this is the earliest ECG change of hyperkalemia. Very good, Avinash, right? So this is how you can see tenting of or tall T waves, right? So this is how you can see on ECG, tall T waves. Clear? Then moving forward, in which type of shock there is elevated CVP, central venous pressure. Now central venous pressure, it is actually reflecting changes of right atrium, right? So it is reflecting pressure changes in right atrium. So if there is any condition, very good Aditi, very good Avinash. So if there is any condition which is leading to increase in pressure in heart chambers, that will obviously increase the CVP. So increase in the pressure of the heart chambers because is possible because of cardiogenic shock, right? So cardiogenic shock, right? So this will indirectly increase the CVP because there is a failure of the heart as a pump. He is not pushing the blood forward, and there is backward hydrostatic pressure that will be reflected into the raised CVP. Clear? So this is cardiogenic shock. Cardio is heart, genic is generated. Then next question, a young male presents with high grade fever and there is inflammation of knee and ankle joints, and this is fleeting in nature. There is history of occasional palpitations and there is a past history of sore throat. Then ECG is showing prolongation of PR interval. I think this is a very good Avinash. This is because of left ventricular failure or left heart failure. Now, I think this is a classical case. Like here, a young male with fever, then fleeting joint pains, then past history of sore throat, and prolongation of PR interval on ECG. So if we just club all these words like fleeting joint pains. Now what is this fleeting joint pains? It is also known as migratory polyarthritis. Right? So this is migratory polyarthritis. Now migratory means moving from one place to another place. Now here it means that on one presentation, a patient will say that there is pain in my knee and ankle joint. And when you call the patient after say 2 months or 3 months, he will say that my knee and ankle is okay. Now I am having pain in shoulder joint. Maybe after few more months in another visit, he will say that my shoulder is okay. Now I am having pain in elbow joint. So it means the joint pain is moving. It is not fixed to one joint, and it will shift from one joint to another, right? So this is one important feature here. Then second is fever. Then third point here is increased PR interval on ECG. Clear? And there is a past history of sore throat, which is usually because of group A, beta, hemolytic streptococci. Now, if you look closely here, these two are minor criteria, right? And this one is, of course, one of the major criteria. And I think most of you can catch the word Jones here. So, what your condition has to be? It has to be rheumatic fever. Very good. So, this is rheumatic fever. So, this is how you have to reach up to your answer without getting into the trap of options. And that's why I don't keep the options, because the moment you see the options, you have this tendency to mark it whatever comes to your mind first. So it's better you read the statement, take out the clues, derive your answer, and I'm very sure you will never be wrong. And those, like, the moment you see the history of, past history of sore throat, you can think of like PSGN, but remember in PSGN, of course, there is a past history of sore throat, I do agree with that, but this is not the only thing which you need to take into consideration. There has to be hematuria, clear? There can be raised blood pressure, there can be RBCs, dysmorphic RBCs in urine, right? So, and most important keyword is cola-colored urine. So, the presentation is more towards kidney. Fine? Then only your answer will be PSGN, right? So, here you need to understand the stem of the question, and yes, at times we can just mix up, but I am very sure if you remember these keywords in mind, you will not do any mistake in exam. Okay, so the answer is rheumatic fever and not post-streptococcal glomerulonephritis, because we are not getting anything related to kidney here. Then moving forward, a patient is having palpitations and there is irregular radial pulse, and ECG shows absence of P waves. Mir, no problem. Very good, Atithi, very good. The moment you have this word, I think there has to be no confusion. Mir, absolutely right, gentlemen. This is atrial fibrillation. Clear? So this is atrial fibrillation. Absence of P waves. You will see only QRS complex. Now, there is one more condition which needs to be, differentiated from atrial fibrillation, and that is atrial flutter. And I'll just give you 2 points to remember from exam point of view. Number one is in terms of heart rate, and number two is in terms of ECG findings. If you remember these 2 points, I'm very sure you will not do any mistake in exam. Heart rate in atrial fibrillation is little high, it around 350. In atrial flutter, it is comparatively less. Very good, Aditi, very good. So here there is absent P waves. Okay, this we have already discussed. Absent P waves. And here we will get sawtooth P waves. Very good, Aditi. Right? So sawtooth P waves. Now if you remember, if you know the basic of ECG, we know that P wave is because of atrial depolarization. So everything this is because of this atrium. So P wave is because of atrial depolarization. Now what happens in atrial fibrillation? There is Mir, yes, you are absolutely right. Avinash Bhai, you are absolutely right. So what happens? There is no proper contraction in atrial fibrillation because see, the heart rate is so fast. So what the atrium is doing is simply vibrating, and if it is vibrating, it will not produce any noticeable P wave, right? And therefore the term is fibrillation. Fibrillation means simple vibration. So this is atrial flutter, atrial fibrillation, and I'm very sure you won't mix up. The moment you get the word absent P wave, straight away jump to your answer, atrial fibrillation. And the moment you have sawtooth P waves, straight away jump to atrial flutter. And at times, if the question is very lengthy, always look for that specific word that is sufficient to mark the answer, right? So rather than exploring all the options, if you get any of the keywords, I think there is no sense in running after the other statement, other points in the MCQ statement. Moving forward, elderly male having breathlessness and occasional episodes of chest pain. Now there is a high volume pulse and BP is 150/70 millimeter of mercury. There is displacement of apex beat which has gone to the left of the mid-clavicular line, and auscultation is showing, auscultation is revealing a diastolic murmur. Now, this question might look little difficult, but there are many keywords, right? One is high volume pulse, right? So I'll write here high volume pulse. Then second is blood pressure of 150/70 millimeter of mercury. Then third, I will write there is diastolic murmur. Now, why I am mentioning only these 3 points? Because if you know about even one of them, you can think of the answer here. Now, high volume pulse is also known as collapsing pulse or water hammer pulse or Corrigan pulse. Right here, what will happen when you palpate the radial artery? Very good, Avinash, perfectly you got it. The moment you feel the radial pulse, you will feel as if there is a large volume of pulse which is coming, striking the examining finger and disappearing all of a sudden. So this is high volume pulse. Now, what is the catch in blood pressure? One might say that it is high blood pressure, but I'll take it in another way. 150/70, that comes out to be 80. And this is actually pulse pressure. So what I'll say, there is wide pulse pressure or increased pulse pressure. This is one more feature of AR. Manoj, you are absolutely right, gentlemen. And third, diastolic murmur, especially early diastolic murmur, this is also AR. So this is classical case of aortic regurgitation. Fine. Now diastolic pressure, I think most of you can understand. The moment, like suppose if this is the systole, right? This is the diastole, this is the, this is like the whole systole phase between the S2 and the S1. So this is S2, this is S1, and this is the entire diastole phase. Now, before the diastole, the heart was in systole. So this is systole and this is diastole. So what will happen during systole? The left ventricle is contracting, it is pushing the blood into aorta, and the closure of the aortic valve. Now we are talking in terms of left side because we have to discuss AR, right? So the second heart sound, which is because of the closure of aortic component of the second heart sound, that will produce S2. But soon after that, since the aortic valve is incompetent, the blood will flow back into left ventricle, and that will produce a murmur. So this is in fact early diastolic murmur. So the moment you have diastolic murmur, think of AR, right? So you have three important key clues in this question, and even if you know anyone, if you know this, jump to AR. If you know this, jump to AR. Otherwise, jump to AR. So either of the three, I think most of you can be correct. So just make sure that these are the key points related to AR. Moving forward, a 16 years old boy with dyspnea on exertion, coughing out of blood, hemoptysis, and occasionally paroxysmal nocturnal dyspnea, right? Paroxysmal means there are episodes. Clear? Episodes, not regular. Maybe today, maybe after 1 week or 1 month. So episodes. Nocturnal is night. And I think dyspnea, all of you can understand, difficulty in breathing. So hemoptysis, blood in sputum. But the most important catch here is joint pains 5 years back. So I think all of you can make the diagnosis here. If any patient having joint pains later on presenting with any feature of related to heart or related to lung, you can think of the rheumatic heart disease. Clear? So this is rheumatic heart disease, and the condition here which usually we see in clinical practice is mitral stenosis. Clear? So very good, Avinash. This is rheumatic heart disease, and the condition which is discussed here is mitral stenosis, which can present with hemoptysis, pulmonary hypertension, dyspnea, then hoarseness of voice. Okay, so this is classical rheumatic heart disease. Although the key points are not that specific, but still sufficient to reach up to the answer. Moving forward, a patient of alcoholism, now having ophthalmoplegia, and answer it nicely. So global confusion, ophthalmoplegia, and ataxia. Yes, very good, Mihir. Very good, Avinash. This is classical Wernicke's encephalopathy. And I would like to add another word here to complete the mnemonic. This is thiamine. Clear? So you can remember this mnemonic, and I think all of you must be knowing that as well. Now, a lady presented with restlessness, inability to concentrate on work, and fatigue, and there was pallor. So I think there is something related to anemia here. Neurological is normal, and there is no neurological deficit, but what we see, a low hemoglobin, yes, this is correlating with anemia, and there is raised MCV with raised homocysteine levels. Now MCV correlates with the size of RBC. So if the MCV is more, there is macrocytosis. Clear? If the MCV is more, it means the size of the RBC is more. Now, which anemia presents with bigger size of RBCs, raised homocysteine? I think most of you can answer it very nicely, because there is only one condition which shows a larger size of RBCs. Avinash bhai, this is megalo. Clear? Blastic anemia. Fine? So this is megaloblastic anemia, and I think the moment you find the word megaloblastic, what is your answer? It has to be vitamin B12 or folate deficiency anemia. Fine? Yes, Aditi, absolutely right. So this is important thing here. This is raised MCV. If I have kept the word reduced MCV, this is mean corpuscular volume. It means small RBCs. This is known as microcytosis. Then you can take either iron deficiency anemia or thalassemia, right? So, clear? So just take this important keyword. Raised MCV, yes, Avinash. So no, not an issue. See, as a human, we all can do mistakes, na? But the thing is that you should rectify the mistakes and do not repeat in the exam. That is the purpose of all these sessions. Anyway, moving forward, again a case of ABG analysis, and here we can see that there is a case of COPD, right? And then he is having shortness of breath, fever, productive cough with yellow-green sputum. Now, this is somewhat related to diagnosis of pneumonia. It can be pneumonia, sorry, not pneumonia, bronchiectasis, because this is a case of COPD, right? So it's already written here, COPD. So we cannot think of pneumonia in any way. This is bronchiectasis. I'm extremely sorry. Clear? So this is bronchiectasis. Yes, if there would have been no mention of COPD, then we can think of pneumonia as well, right? So this is bronchiectasis, and now what we can see in the EBG analysis, pH is 7.3, so it is acidosis. One thing. Then PCO2 is 68, so this is raised, so we will use the word respiratory. Clear? And then bicarbonate is normal, so it means uncompensated. Clear? So this is uncompensated. So the answer has to be very good, Aditi, very good. Respiratory acidosis, uncompensated. Fine. If the bicarbonate is more, then we will say that yes, it is going towards compensation. Now it is uncompensated because Avinash, absolutely right, gentlemen. Moving forward. So I think these questions won't be that tough for you. The moment HCO3 is also rising to counteract this respiratory acidosis, we will go for partially compensated or full compensated depending on the pH, right? But for this question, since there is no change in bicarbonate, it's in the normal value, so we'll simply say that it is uncompensated respiratory acidosis. Then moving forward, a patient with cough, expectoration, especially in the early morning hours, and the sputum was yellow in color, and more importantly, this increases on turning from left to right side. So what case is this? Early morning, productive cough, and there is somewhat, you can say, postural increase in the drainage of sputum or the expectoration, and this is a very classical feature of bronchiectasis. Clear? Because this is commonly involving the left lower lobe. So the moment the patient changes the posture from left to right, there will be increased drainage of that secretion, and therefore the patient, when he'll cough, the sputum will produce, productive cough. So this is bronchiectasis. There is increase in postural drainage, and this is what is actually a part of treatment as well. We promote postural drainage so that the secretions are taken out of the respiratory tract, right? So this is postural drainage. Now moving forward, 35 years old male complains of itching, jaundice, mood disorders, and tremors. and I shows a golden brown ring in the Descemet's membrane. I think the moment you have all these words, straight away you can mark your answer. Like here you can see this is hepatic involvement. Clear? Yes, Avinash, perfect man. This is neuropsychiatric. Clear? And this is of course eye or ocular involvement. So this is ocular involvement, you can say. So the moment you have this Keshav-Fleischer ring, actually this is Keshav-Fleischer ring. So moment you have this kind of, yes, Mihir, absolutely right. Aditi, absolutely right. This is Wilson disease. But I would like to share few more words in terms of terminology. It is also known as hepatolenticular degeneration. Clear? So always and always try to remember some other names of the diseases also, because at times you might not get the word you are searching. So maybe you don't have Wilson disease in the options. They can give you hepatolenticular degeneration or chalcosis. So you should know that yes, all the terms are actually representing one particular condition only, right? Because I have seen one question where there was no mention of Wilson disease. The term was hepatolenticular degeneration in the answer. Clear? So anyway, I think most of you must be good with this entity. Then moving forward, a 25 years old man presents with nausea, vomiting, diarrhea with crampy abdominal pain, and he say that he have taken rice in his last meal. Now, which organism can cause this kind of presentation, especially in incubation period of 1 to 6 hours? Yes, I think it's not that tough. So one way of gentlemen, this is not rice water stool. This is rice preparation. It means the person has taken fried rice. Now here, the moment you get this word 1 to 6 hours, yes, you can think of Staph aureus. Nothing wrong in that. But that is not the answer here. The answer in this question is Bacillus cereus. Clear? Now why Bacillus cereus? Because Staphylococcus aureus is because of consumption of dairy products. But what we are getting in the question, this is rice. So this Bacillus cereus, this is because of consumption of fried rice. Very good, Avinash. So got the clue? This is fried rice. So the answer has to be Bacillus cereus. Fine? And not Staphylococcus aureus, which is specifically seen after dairy products consumption. Although the incubation period for both the entities is same. So, Mihir, Avinash, absolutely right. The answer here is Bacillus cereus. And you can take the word cere from here, that might relate to cereal. So that is rice. Anyway, so this is enough for this session. I'm extremely thankful to all of you for giving your valuable time. And we'll come back with some more sessions. Till then, keep on studying. God bless. Bye-bye.